Okay, welcome back, everyone. We are going to get started with our oral presentation session. And I will be very briefly introducing the title of folks' presentations. But if you want to give a more in-depth introduction of yourselves, please do so. Just so you are aware, we do have an abstract book for the oral presentations and the poster presentations, which will be available again in a few weeks when the conference is fully archived. So with that, I am going to hand over the podium to Rachel Anderson to discuss visual aids and shared decision making.
All right. Hi, everyone. My name is Rachel Anderson, and I'm a second year adult neurology resident here in Rochester. And today I'm going to be talking about a case that I was involved in last year in the hospital that was a relatively complex shared decision making discussion for which we used visual aids to help us guide that conversation. So, just for a brief definition of what shared decision making is that really resonated with me, is that it's really a process through which the patient and the provider are active members involved in making the decision together, considering the risks, benefits, patient values, and preferences in that conversation. So, having these discussions is a really important way of providing patient centered care that we all strive to do, and using visual aids can be an effective way to help guide these conversations, as hopefully this case demonstrates. So, just for a little bit of case background, this was an 85-year-old female who was hospitalized with post ERCP pancreatitis. So, she had presented from home to the emergency room with abdominal pain, nausea, vomiting, and confusion. And her labs and imaging were concerning for acute cholangitis with an obstructing pancreatic mass, concerning for malignancy. So, in order to diagnose that pancreatic mass, the patient underwent two ERCPs with two EUS guided biopsies, but unfortunately, these returned non diagnostic. So, although we had a high suspicion for malignancy, we did not have tissue confirmation of that. And the patient was required to stay in the hospital for her ongoing pain, nausea, and poor oral intake, requiring IV pain medications and IV fluid support. So we had a case dilemma for this situation because our suspicion was high for underlying malignancy, but we did not have definitive diagnosis of that. And unfortunately, our way of doing that with the EUS guided biopsy was leading to ongoing pain, nausea, and prolonged hospitalization for the patient. The patient and the family were reasonably frustrated with this and confused with the diagnostic uncertainty. And just for a little bit more background information, before coming into the hospital, the patient was living independently. And throughout her hospitalization, she continued to voice the desire to return home and spend time with her family. So, because of the complexities of this case and the high suspicion for malignancy, we involved our oncology colleagues to help guide the conversation. And because of the patient's continued preference for comfort and quality of life, we also involved our palliative care colleagues as well. So we brought everyone all together like all good goals of care conversations. So we brought oncology into the room, we brought our palliative care colleagues, and us, the primary service, the GI service, and made sure that the patient and all the family members that she wanted involved in the conversation were able to be present as well. So, like most good goals of care conversations, we all made introductions, we explained all of our roles in the discussion. And then we talked about how this conversation would be one where we share information and then come up with next steps for management moving forward. And what was really kind of unique about this case is we used the whiteboard to rely on using kind of visual aids as well to help guide the conversation and make more clear where we were at and what we were proposing as management going forward. So first, we started out with sharing the information that we had gathered thus far in a timeline of events to make clear the information that we had and kind of the point that we were at. So we first kind of described how the patient had originally presented, the imaging and the lab findings that were found and made us concerned for malignancy. With that, we discussed how the patient had gone through 2 ERCPs, and unfortunately developed pancreatitis after both procedures. We had done 2 EUS guided biopsies that had unfortunately had returned non-diagnostic, and this required the patient to continue to remain in the hospital for ongoing IV pain medication and fluid support. So this timeline helped lay out the information that we had gathered up until this point and kind of make clear to the patient and the family, just summarizing the information that we had, everything that had gone into the hospitalization, and kind of the ongoing uncertainty that we had at this point. Then we talked about management strategies going forward, and oncology proposed that this be directed kind of by the patient's plan to either pursue treatment or decide not to pursue treatment in this situation. So we laid out the two options. One would be to pursue treatment of the pancreatic mass. So this would require a repeat EUS guided biopsy to get tissue confirmation of the diagnosis. And then this would help us determine treatment strategies going forward. So this would likely entail extensive surgery with a Whipple procedure and at least 2 cytotoxic chemotherapy agents. This strategy would likely require longer and recurrent hospitalized stays for the patient. The second option would be for the patient to decide not to pursue further treatment of the pancreatic mass. So, what this would involve is us supporting the patient through the most recent episode of post ERCP pancreatitis, and then focus on the patient's comfort, her goal of getting home and returning to her family. However, it would involve ongoing diagnostic uncertainty. So with these two options, we laid out the benefits and the risks of both options. So for pursuing treatment, the main drawbacks that we could see were that it would require another EUS guided biopsy that we had seen cause the patient a significant amount of pain and side effects in the past. It would require likely lengthy times of stay in the hospital, both around the likely surgery and then around likely the chemotherapy agents that she would need to have. And then it would also involve more morbidity with side effects including nausea, vomiting, abdominal pain, fatigue, likely increased risk of infection, among others. But the benefits of that would may be that we would increase the patient's life expectancy. And then option two, with the patient not pursuing treatment, would have the benefits of maximizing the patient's time at home with her family, reducing morbidity associated with the procedures, surgeries, and medications that would otherwise be involved in the treatment. And then we also highlighted that throughout the hospitalized stay, like we had discussed, it seems as if the patient had continued to value returning home, being surrounded by her loved ones, her family, and just having that quality of life. So we discussed that all together and how that seemed to, from our perspective, best align with option two, but obviously opened the floor up to the family and the patient for time to ask questions as well. So with that, we kind of allowed the family and the patient time to discuss among themselves after making sure all of their questions had been answered at that point. And the following day, while there was continued to be diagnostic uncertainty, the family and the patient felt confident in making the decision that they did want to focus more on the patient's comfort. They were comfortable leaving kind of the question unanswered in terms of what the final diagnosis truly was. but felt at peace that they knew that this decision was in line with the patient's goals of care and would ultimately lead to likely the highest quality of life for the patient moving forward. So I think this case just well demonstrates that using visual aids can help guide goals of care conversations, especially when there remains diagnostic uncertainty, um, and um, and it allows providers to effectively um, engage in shared decision making to deliver the patient centered care that we all strive to do. So with that, I can open up the floor to any questions that you might have.
All right. Yes, you're very welcome.
Thank you so much for the nice presentation. One question that probably is due to the lack of my knowledge is, do we have any existing record of diagnostic uncertainty in the EHR right now? So is there any ICD code, anything that we can look at the EHR and say, in this period of time, this page, there was a diagnostic uncertainty going on?
Sure. Yeah, that's a great question. I don't, not that I know of. I think we generally just go with a more non-specific diagnosis than in that case. So we used pancreatic mass rather than, pancreatic malignancy or a particular type of cancer that we would have been able to come up with if we had a biopsy. But typically we just use a more non-specific term. But I think that could be useful for research.
Thank you.
Thank you. That was lovely. Quick question. When you laid out the options, the was it clear to you and the rest of the people in the room what were the issues that mattered most to the patient? And if so, what made you organize the presentation on the whiteboard by those options versus organize the presentation in the whiteboard by those issues? So for instance, the patient said, I want to go home and be comfortable. So okay, so that's one issue. How does option A and option B behave on that issue? I want to be, I don't know, pain free. I don't know what other, that's the one I heard, but
Sure.
there might be other issues. What made you organize the whiteboard that way?
Yeah, I think we ultimately ended up organizing the whiteboard that way as the question continued to center around what are we going to do next? And with that diagnostic uncertainty, oncology had proposed choosing the management strategy that would ultimately fit whether the patient was going to pursue treatment or not. So I think it was mostly based on the question that the patient and the family kept asking about, like revolving around the uncertainty of that. I think there could have been many other ways that we could have laid things out as well. I think that this just helped guide next steps and then allowed them to take the time to step back and then see where those steps would end up landing the patient and if that would align with the goals or not.
Great. Thank you very much.
Thank you very much for the question.